You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
When every decision matters, you need trusted medical intelligence. Medscape AI synthesizes peer-reviewed evidence and Medscape's expert-validated content in seconds, delivering clinically verified answers you can trust. Join over 13 million Medscape members on the world's leading platform for clinicians. Start using Medscape AI on the web or in the Medscape app. Medscape AI, trusted medical intelligence.
Hi everyone, this is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for June 26, 2026. This week, some listener feedback on valvular heart disease, statins and frailty, left atrial posterior wall ablation fails again, interpreting medical test, and AI ECG reading. But first, an announcement. As has been the long history of This Week in Cardiology, we break next week to observe America's most important holiday, which is Independence Day. Our hospital will be a ghost town next Friday on the eve of the 4th of July, so this podcast returns on July 10th. Listener feedback. My former colleague, Dr. Anthony Pearson, now known as the Skeptical Cardiologist on Substack, which is a worthy Substack to read, wrote to me regarding my last week's coverage of the Preview Valve study, which was a novel study from the CRF group, wherein they chose a random sample of older adults who filled a prescription at CVS or Walgreens pharmacy. They then invited these patients to have a formal echo in their home, actually, to assess for valvular heart disease. And the group actually sent out invitations to more than 660,000 people, and ultimately about 3,300 people completed the informed consent process and agreed to enroll in the study, and 3,000 of them completed the study procedures. They found that valvular heart disease was common at about 5% in the ages 65 to 69 and a gradient up to 15% for 80 to 85-year-olds. Now, after giving the authors kudos for such a novel study, I then worried about disease creation and disease recognition campaigns. The authors did not make such a case, but it's not hard to imagine that companies that make these valve clipping sorts of devices creating such advertising campaigns. Dr. Anthony Pearson, who is an echo expert, wrote to me to agree with my worries, and he pointed to the disclosures of the authors who are clearly structural heart doctors who treat valvular heart disease. He also pointed out something that's very, very, very important in echocardiography. It's a point that Dr. Harvey Feigen made to us fellows many years ago at Indiana, and that is that Anthony Pearson writes, the degree of valvular heart disease by echo, with the possible exception of stenosis, is very subjective and will vary depending on the machine, the tech, the reader, and readers and techs can easily be biased toward overgrading. Now, I see this often. He is correct. An echo is done during an obvious volume overload and hyperadrenergic state. The report comes back severe MR because the jet looks colorful. Such a report can easily lead to consideration of valve interventions and overtreatment. He had an echo done in that same patient after treatment of the acute episode, often shows mild to moderate MR or TR. It's seemingly miraculous. Now, such a lesson seems almost too elementary for this podcast because I know it goes to cardiologists, but I see valvular shenanigans to this day. Dr. Feigenbaum taught us the timeless lesson that regurgitant lesions are pre- and afterload dependent. The dynamic nature of these lesions is substantial, and regurgitation is best assessed when the patient is euvolemic and on medical therapy. The other point that Dr. Anthony Pearson wrote to me is the subjective nature of grading these jets. I mean, if you thought EF was subjective, MR and TR are even worse. I swear you could do a study like the judge study showing that judges give harsher sentences before lunch than after lunch, and I bet you'd see similar findings with grading these MR and TR jets. And I thank the skeptical cardiologist who may be even more skeptical than myself. All right, first topic today is statins and frailty. The European Journal has published an observational study from Harvard researchers who looked at the association between statin use and the chance of being diagnosed with frailty. Now, you would think that if such lofty institutions, such as Harvard and the European Heart Journal, are involved, the study would be good. But if you thought that, you would be wrong. I cover the study because it's rare that such a flawed analysis make it to the level of the European Heart Journal. And the lessons of this study reiterate the problem with observational retrospective non-random comparisons. Let me quote from the introduction. Quote, whether therapeutics that lower CVD risk and inflammation can also lower frailty risk is unknown. Statins represent a promising class of drugs that may also slow biologic aging. Now, these two sentences are obviously trying to convince you that statins are so amazing that they can prevent aging. The study uses the VA database from 2002 to 2018, and they formed two groups. Get this, 987,000 non-statin initiators versus 290,000 statin initiators. They then did propensity score weighting to balance baseline characteristics, and Table 1 miraculously shows 0% differences in the two groups in basic clinical things. And here are the results. After propensity score weighting, new statin initiators were less likely to experience incident frailty. Hazard ratio 0.76. Confidence intervals, get this, 0.57 to 0.76. The narrowest confidence intervals I have ever seen. And this was 24% reduction in statin initiators versus non-statin initiators for frailty. Now, in absolute terms, the unadjusted event rates were 153 events per 1,000 person years among statin initiators and 111 events per 1,000 patient years in non-initiators. A translation that's akin to about 1.5% versus 1.1%, or a delta of 0.4%, an NNT of 250. And the author's conclusions. In the European Heart Journal, Harvard researchers, quote, statin initiation was associated with a significantly lower risk of incident frailty or death among older U.S. veterans, including those who were pre-frail at baseline. Now, my comments. It's hard to believe that A, this study was done, and B, that the European Heart Journal published it. Now, I'll start with the global issues. We know that statin drugs reduce the risk of non-fatal cardiac events by about 25%. In absolute terms, that's about 1% or 2%, depending on the baseline risk. It might even be more than that, but it's real, and it's foundational for secondary prevention of coronary disease. But come on, my friends, frailty has to be one of the most multifactorial conditions I can think of. Yes, a big anterior MI or stroke could cause frailty, but so can about 100 other things associated with aging, like Parkinson's disease, dementia, COPD, immobility, arthritis, falls, you name it. It belies common sense to posit that a 1 or 2 or 3% absolute risk reduction of non-fatal cardiac events could affect global aging disease diagnosis like frailty. Second point. While the 24% reduction in frailty seems large, the absolute difference was 0.4%, or an NNT of 250. So even if causal, which it surely is not, the effect size is tiny. And the lesson here, I think, is that when a sample size are in the millions, tiny effects easily can meet statistical significance. I mean, look at those confidence intervals of 0.75 to 0.76. Next point, in observational studies, I always look to see when the Kaplan-Meier curves diverge. And here you have to look in the supplement to see these. There's pretty early separation of the curves in this study, which is implausible because statins would take time to exert its anti-frailty effects if it had any. I think, but the most important and fatal flaw of this analysis is that surely statin initiators are different than non-initiators. A, people who accept statins are more likely to do healthy things to help them not become frail. B, doctors are surely more likely to prescribe statins to older adults more likely to not be chronically ill, because even the greatest prevention evangelist would look at a veteran with 10 medical problems and 20 medicines, and they would probably not think a statin would help. But on the other hand, if you had a mobile, active, older adult who was on a few medicines but had a high LDL, you might easily start a statin. So the lower rates of frailty are simply because less chronically ill patients get initiated on statins, and propensity scoring cannot sort out all these differences. Finally, for the purists who look at studies like this, the authors offer no serious falsification analyses. So it's almost certainly that this is just simply biased comparison groups. All right, next topic is left atrial posterior wall isolation falls again. Now, this is a little bit EP specific, but there are evidence-based medicine's lessons in this story. When you do PVI for AF ablation, the two circles around the pulmonary veins leave a strip of posterior wall myocardium unablated. Some groups have long recommended ablating that area on the back wall of the left atrium because the myocardium there is an extension of the PV-type musculature and therefore could be triggers for AFib, just like the PVs can be triggers. Some of the groups who advocate for this also have great eminence, so that's important. The downsides of posterior wall isolation, though, are many. A, it increases procedure time. B, when using RF or cryo thermal energy, it increases the risk of fatal, as in a young person dies, thermal damage to the esophagus, which lies immediately behind the posterior wall. And C, that the posterior wall has many epicardial connections. So even when you think you've isolated it, you probably have not done so. At least you've not done it durably. The European Journal has just published a rapid communication of the Japanese-led Cornerstone AF trial, which tested AF suppression with PVI plus posterior wall isolation versus PVI alone in 517 patients with advanced forms of AFib, like long-standing persistent AFib. And, of course, they found no differences in AF recurrences. They did find that the procedure time was 22 minutes longer in the posterior wall isolation group. Fortunately, there were not any major complications in the posterior wall isolation arm. Now, this Cornerstone AF trial adds to the 2023 Australian CAPLA trial, where 338 patients with persistent AFib were randomized to posterior wall ablation plus PVI versus PVI alone, and they too found no differences in AF outcomes. So my comments are that both these trials use thermal energy, but now PFA has largely replaced thermal energy to do AF ablation. And we have multiple different systems for delivering PFA, but most commercial PFA systems use large multipolar catheters. And these make posterior wall isolation easy because instead of making a 3 millimeter thermal lesion with an RF catheter, you can deliver PFA to these much larger areas with literally 5-second PFA deliveries. What's more, and I think maybe more important, is that PFA can ablate the posterior wall without esophageal injury, as extracardiac heating is nearly non-existent. Note I said nearly, but nearly non-existent with PFA. Now, I've seen no reports of esophageal fistula when only PFA is used in the left atrium. I'm not saying it can't exist, but we haven't seen it yet. In my hospital, I use a dual lattice tip 9 millimeter PFA catheter to do AF ablation, and isolating the posterior wall adds a few minutes, not 20 minutes, like 2 minutes, and is super easy. I use posterior wall isolation currently because the two antral circles that I use for PV isolation nearly touch each other posteriorly, and a couple of PFA delivery gets the posterior wall isolated, gets the job done. Now, the strip of posterior wall is so small that I worry that it could be proarrhythmic. In other words, that a flutter could rotate around the roof. I realize this practice is an evidence-free practice. I realize that. I accept it, but it's truthful. The question the EP community asks now is whether posterior wall isolation with PFA will be different from RF. And I searched using Claude, and Claude identified two ongoing CAPLA and Cornerstone type trials with PFA, one from South Korea and another from China, and I suspect that there'll be others. Now, in favor of PFA posterior wall isolation is that PFA may be more durable than RF. You can surely deliver more energy to the posterior wall with PFA due to its cardioselectivity and the very low worry about the esophagus. Yet those pesky epicardial connections may not be ablatable even with PFA. By the way, not one, but two patients this month asked me after their ablation procedure how I know where to ablate for AFib. And of course, it's answers to these key questions that will lead us to better results much faster than any fancy EP catheters. The answer, of course, for the listeners is that we don't know where to ablate. We ablate the same place in every patient with AF, and this is a knowledge deficit. All right, next topic is a very interesting paper, and the title of the topic will be, Does this display of test results improve clinical decisions? And Portuguese internist Dr. Bernardo Pimentel pointed me to a nice RCT from a University of Colorado group on how the display of a medical test may improve clinical decision making. New England Journal of Medicine Evidence published this neat study this week. Now, the idea is that many test results, D-dimer, a BNP, troponin, procalcitonin, they're displayed often as dichotomized, normal or abnormal. And surely this oversimplifies use of the test, as everyone knows that these sort of tests occur on a continuum. And a normal value is a just made-up value. It's also well known that clinicians use Bayesian reasoning, whether they are aware of it or not. So the idea here is that a medical test rarely makes a diagnosis. Rather, a medical test shifts the pretest likelihood one way or the others. And the University of Colorado authors were interested in whether presentation of the test results with interval likelihood ratios would improve the rate of correct decision making, though we can speak later about what quote-unquote correct decision making is. This was a multi-center randomized trial of internal medicine residents, attending physicians, and advanced practice providers. And these participants were presented with two fictional vignettes. One case involved a PE diagnosis, and one case involved heart failure treatment. And each of these case vignettes clearly had a correct response, and it was centered on a key diagnostic test result. The vignettes were identical except for participants' random assignment to one of these test characteristic presentations. So the test that determined the clinical action could be displayed A, as a single threshold, greater than or equal to a number. 2, binary test characteristics with sensitivity, specificity, and 3, these interval likelihood ratios. And of course, this data is collected from multiple studies of the test in their literature. For the PE case was presented as a low clinical pretest probability of PE, but the D-dimer was 600. The single threshold D-dimer normal value was less than 500. Now, the binary arm was using sensitivity of 95%, specificity 60%, positive likelihood ratio, therefore 2.4, and negative likelihood ratio 0.08. And for the interval likelihood ratio arm, it was as follows. So the D-dimer of less than 250 had an interval likelihood ratio of 0.03, 250 to 499, 0.06, 500 to 749, which it was in this case, 0.3, and just a gradation up between, like, say, 2,500 to 4,099, 4.2, greater than 5,000, 6.6. Now, at this point, I want to just do a little pause or sidebar on likelihood ratios. A positive likelihood ratio is the sensitivity, which is the true positives, divided by 1 minus the specificity, which is the false positives. A negative likelihood ratio is 1 minus the sensitivity, which are the false negatives, divided by the specificity, which are the true negatives. So the classic example, and I'm going to cite this, is Gerd Gigerenzer's quiz of doctors on the chance that a woman with a positive mammogram has cancer if the test has a sensitivity of 90% and a specificity of 90%, which is seemingly very good. Most doctors get this question wrong, and the incidence of breast cancer, which you have to know, is 1%. So the likelihood ratio, positive likelihood ratio here, is 0.90 divided by 0.1. That's 9. So roughly, 9 times 1% disease prevalence is 9%. So the chance that a woman with a positive mammogram has cancer with a 90% test is 9%. And this example shows the importance of the pretest value, right? Because mammography has a pretty good likelihood ratio of 9, meaning the actual data, moves the pretest value by 9x. But since the prevalence is so low at 1%, the vast majority of positive tests are false positives. This breast cancer example, I think, exemplifies the fact that even if you have a strong test, a positive test, a likelihood ratio of 9, if the pretest likelihood is low, then the chance that the test detects the disease is quite low. So in the case of the PE, the D-dimer of 600 has a likelihood ratio of 0.3. So it actually decreases the pretest likelihood. Now, the heart failure vignette of this study was a bit different. Here, the patient presentation was consistent with a high clinical pretest probability of heart failure, but they give you a BNP slightly less than the cutoff value. So the single threshold here was a BNP less than 100 is normal, and the BNP is 90. So using the binary test, it was sensitivity 90%, specificity 76%, positive likelihood ratio 3.8, negative likelihood ratios 0.13, and the interval likelihood ratios were as follows. So with the BNP less than 50, the likelihood ratio is 0.1, BNP 50 to 80, 0.33, BNP 81 to 150, the likelihood ratio is 1, so it has no effect. And BNP greater than 150, the likelihood ratio is 5. So if your BNP is high, that increases your pretest likelihood by 5. Now for the trial, 1,700 clinicians were invited to do the survey, and 611 were randomized to the 3 groups and the 2 vignettes, about 200 per group. So that's 200 clinicians using the single threshold normal or abnormal, 200 using the binary test characteristics with specificity and sensitivity, and 200 using the interval likelihood ratios displayed. So in the PE case, the correct answer, the primary endpoint of the study, was to not order the CTA because it was a low probability and the borderline D-dimer was not enough to shift your pretest suspicion. In the heart failure case, the correct answer was to give diuretic because the pretest suspicion was high and the borderline normal BNP was not enough to change your high clinical suspicion pretest. And the main result was the correct response rate was 82.2 for the threshold group, 75 for the binary group, and 93.4 for the ILR group. So the correct response rate in the interval likelihood ratio group was higher than in the threshold group by 11 percentage points, and that was significant, and higher than the binary group by 18 percentage points, and that too was significant. And interestingly, the differences were much greater in the PE care group than the heart failure group. And the authors conclude that this trial suggests that interval likelihood ratios may offer a more intuitive and effective alternative to the current approach. A thoughtful design of how test results are displayed, including the use of these interval likelihood ratios, may meaningfully influence clinical decisions and ultimately improve patient care. My comments: I really like this idea and this trial. In my thinking, anything that gets clinicians thinking in a more Bayesian way is an improvement. And I've said this a gazillion times, but it's worth repeating. Medical test and clinical trial results don't give answers as much as they shift pre-test impressions. In the PE case, the pre-D-dimer suspicion was very low. Maybe the heart rate was normal of the patient, the O2 sat was normal, and there were no risk factors. Now you have a D-dimer just above that normal threshold, but the likelihood ratio is actually less than 1. So a D-dimer of 600 makes you less worried because the likelihood ratio decreases your pretest clinical suspicion. Now, had the D-dimer come back at 2,500, that strong data would shift your preclinical suspicion. Now, by the way, it's the same for trials. Take appendage closure. I know I talk about this all the time, but the PROTECT and PREVAIL and PROG-17 trials taken together should give you a highly pessimistic view of appendage closure versus anticoagulation. Then the German closure AF trial comes out with inferior results for the appendage closure versus uh, anticoagulation, and Champion AF also has a higher stroke rate and no major differences in bleeding. So this new data only strengthens your pessimistic views. So another thing I like about this paper and the author's discussion of it is that instead of just implementing the policy of labeling test results with likelihood ratios, they study it in RCT form. Now, there are weaknesses of this trial. It's likely not a random sample of clinicians who agreed. There were substantial amounts of physician dropout, and they only used 2 clinical vignettes. You'd want more trials, and perhaps you'd want cluster randomized stepwise trials looking at implementation in the real world. But contrast this movement with the hospital readmissions penalties policy people. They just implemented the policy without trials, and now it looks like their well-meaning policy of penalizing readmissions harms patients with heart failure. Now, a final note on this trial has to consider the correct answer, right? In the PE vignette, the correct answer was not ordering the CT. And while I love Bayesian reasoning, I am not so naive to think that there are other forces affecting clinician behavior besides probability density functions, and that is medical liability. PE is one of those conditions in the US for which doctors are sued for missing. So in real life, the pragmatic doctor might order a CT to protect him or herself no matter about the pretest clinical suspicion. And this is where a study on these clinical vignettes is nice, but they may not translate well into real practice. So you'd want to see this study interval likelihood ratios displays done in cluster randomized form in the real world. But good study, and thanks to Dr. P for pointing me to it. All right, the final topic today is AI and the ECG and how the AI can save doctors and patients. The journal Nature Medicine published a case report from New York where AI reading of the ECG supposedly saved a life. This according to the New York Times coverage. Yes, New York Times covered a case report. And this case went viral on social media, and as such, it inspired lots of commentary. So here it is in brief. A 45-year-old man presented to the emergency department with 4 days of progressive dyspnea on exertion, productive cough after recent exposure to wildfire smoke. A review of his symptoms were negative for everything else like fever, chest pain, lower extremity vomiting, abdominal pain. He reported no contact with sick individuals. His medical history was notable for long-term tobacco use and previous treatment for tuberculosis. His family history was negative, and on arrival to the ED, his heart rate was elevated, his oxygen level was normal, and breath sounds were reduced in both lungs. A blood test, quote-unquote, showed a mildly increased marker of cardiac injury. Other laboratory tests were within normal limits, and the chest X-ray, quote, showed no abnormalities in the heart or lungs. The patient was treated with a bronchodilator and steroids for a clinical diagnosis of an asthma flare-up, and his symptoms improved. He was discharged from the emergency department with an albuterol inhaler and referred for outpatient follow-up. An ECG was obtained during his ED visit, which was shown in the paper. Now, the group was part of a trial using an AI model of ECG reading. The subsequent AI identified this patient as high risk for structural heart disease, and they had an urgent outpatient echo, which showed severe cardiomyopathy, EF 10 to 15%, with mitral regurgitation. He was advised to return to the ED and was admitted for further management of heart failure. He ended up having a Lamin gene variant associated with dilated cardiomyopathy, and only 6 months later had a heart transplant. Now, the author's right. The patient represents the first case of AI-detected advanced heart failure leading to heart transplantation. And they added these 2 whoppers. Quote, without this AI-based capability for advanced ECG interpretation, there would likely have been further diagnostic delays for this patient. Given his underlying high-risk genetic mutation, the diagnosis of advanced heart failure may have only been made in the setting of sudden cardiac death due to dangerous heart rhythm. This is the beginning of the next era of medical diagnostics in which AI-based technologies are facilitating the detection of diseases that would otherwise remain undiagnosed. Okay, so my comments. First of all, I've been waiting 30 years for proper computer reading of ECGs. The current 1970s technology is an embarrassment of the medicine profession writ large. That we have allowed such inaccurate reads on the ECGs for this long has boggled my mind. I saw recently a patient who suffered for 2 months with 2-to-1 AV block because his computer ECG read showed sinus bradycardia and the clinician did not notice the block. Likewise, I probably answer a message a week from patients questioning their anterior infarct on their pre-ablation ECG because that's what the computer read shows and the patient sees it. Of course, it's not accurate and usually gets corrected, but that sits in the chart. So I, John Mandrola, welcome better AI reads of ECGs, which should be as easy for AI as playing chess. It's pattern recognition. Come on. I also am no Luddite, and I welcome the addition of AI in medicine as it surely will help us with diagnosis and treatment. But this case is highly problematic and it's full of holes and it's way too hyperbolic. First of all, that ECG is not a little abnormal. It's massively abnormal with a wide, notched QRS, first-degree AV block, and biatrial abnormality. It screams cardiomyopathy. All clinicians evaluating patients should be able to recognize such an ECG as worthy of follow-up cardiac evaluation. Not only that, it's highly unlikely to me that the chest x-ray showed no abnormalities of the heart. An EF of 10 to 15% and a Lammin mutation, this patient probably has a very wide cardiac silhouette. And the positive biomarker was likely a troponin, and these are rarely ignored. Now, I don't know how things roll in New York, but here in Kentucky, a person with that ECG and a troponin would have been put in our OBS unit, which I call purgatory, because you are neither in the hospital nor are you home. A cardiologist would have seen the patient and a diagnosis made in observation. What's more, the presumption that he would have died from his dilated cardiomyopathy before evaluation belies statistics. He's had a Lammin mutation since he came out of his mom 45 years ago. He's lived 45 years and has not had VF. So he was far more likely to have made it a few more days or weeks before being diagnosed, as he surely would have been, since the cause of his dyspnea was not addressed, and in a week or two, he would have called his doctor or come back and said, "I'm still short of breath." My friends, I ask you to do me a favor. We need to spread the word about ECGs. This is a window onto the health of the patient. Please, spread the word. We need to look at the QRS. It should be sharp and narrow. When it is like this case, when it is wide and notched or fragmented, it is so most often because of myocardial disease. Do not blow this off. I think we need a QRS recognition month. Also, I may sound old about this, but if you are evaluating patients with medical complaints and you order an ECG, a $25 test, you should have enough skill to be able to sort normal from massively abnormal without AI. If we are producing clinicians who cannot do that, what are we doing in medical education? So that's it for this week in cardiology. As always, I'm grateful that you listen. Thank you. And remember, if you like this podcast, please give us a rating, write me a review. If you don't like something I said, send me listener feedback. I always learn a lot from that. So until July 10th, this is John Mandrola from the heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the heart.org Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.